All right. Hey, everyone. Definitely thank you for coming in today. Make sure you get your lunch and sign in whenever you can. We're going to go ahead and get started. Just as a reminder, with this slide, we did mirror this presentation off of the national PNHP and SNaP 2022 single payer update. Most of the slides from them fit into our first lecture. And so this lecture and tomorrow are mostly original material from our team. Okay, so yesterday, Megan gave a pretty comprehensive overview of the state of affairs in U.S. healthcare, including the amount of wasteful spending we have that amounts to much worse health outcomes for our population. As we get into today's topic of the Medicare for All bill, I want to tell you up front, the slides get pretty technical with legislative language. So please keep our first lecture in mind, as all of what we're discussing today is meant to address the vast majority of those pitfalls and inequities we discussed on Tuesday. Tomorrow is probably our highest yield session, because if you manage to attend our first two sessions and then tomorrow, you'll be able to advocate for Medicare for All to all of your friends and family effectively, and even be able to meet with legislators to teach, as we will teach you how to prepare for a majority of the counter arguments against Medicare for All. So first, we will watch a brief overview of various proposals designed to fix healthcare and emphasize the importance of a full single payer system. Next, in order to cut through any conjecture and be fully transparent, we actually wanted to break down the 2022 Senate bill on Medicare for All with you and highlight some of the key takeaways from the bill. Then we'll provide brief updates on state and local activism efforts, and then have a short lead into our final lecture. All right, so I'm actually going to speed this up too, just to try to get through the video.
Now that we've set the ground rules and the 5 main questions to consider, let's look at the various Medicare for All plans. The time we take this episode, mid-February 2019, there were 10 that we could get full answers to. How they break down is the topic of this week's healthcare. Let's start with universality. 4 of the plans get us all the way there. The biggest and most well-known is Senator Bernie Sanders' Medicare for All bill. His plan would take Medicare, make it better, and then give it to everyone. How better, you ask? It would now cover vision and dental, drugs, and even long-term care. It would even cover abortion. It would completely do away with employer-sponsored health insurance as well as the individual market. It would also do away with premiums, which, let's be clear, Medicare has right now. So this is Medicare Plus. It would even do away with cost sharing for the most part. It will be paid for through taxes likely, and some fees on large banks. The House Medicare for All bill, put forward by Representative Jayapal in the House Progressive Caucus, is very similar. It too would be universal by simply expanding Medicare to everyone. Abolish employer-sponsored insurance in the individual market, no premiums, no cost sharing. Not as clear as how it will be paid for, though likely through taxes. It's expected that the House will align their bill more closely with the Senate bill in the near future. There are 2 more plans that fight for universality, but with more retention of the current system. The first is the Center for American Progress's Medicare Extra for All. It would enroll all newborns and people turning 65 into Medicare Extra. Therefore, as time went on, everyone would have Medicare Extra, but for now, private insurance would remain intact. In addition, everyone who currently doesn't have insurance would also be enrolled in Medicare Extra. Premiums would be taken out of taxes unless you don't pay taxes, and then you don't have to pay for them. Of course, for everyone with private insurance, you'd still have premiums and cost sharing. It would entice employers to stop offering coverage, though, by telling them that if they do, they could instead just pay a payroll tax and let Medicare Extra take care of it. That would only happen, though, if the coverage seemed better than private coverage, and that's not clear. But over time, everyone would have Medicare Extra, and it's likely that we'd wind up with Medicare for All. The Medicare for America Act is somewhat similar. It's proposed by Representatives DeLauro and Schakowsky. It would establish a Medicare for America program that would immediately enroll those who currently get Medicare, Medicaid, CHIP, insurance on the individual market, and the uninsured. Employers can keep offering private coverage, though, if it's great coverage. Medicare Advantage plans might stick around, so individual private coverage isn't totally gone, and some choice could remain. It'd be paid for with premiums rated by income. Cost sharing would also remain, but it would be eliminated for preventive services and placed on a sliding scale based on income. Unlike Medicare Extra for All, it's possible that employer-based health insurance might stick around forever. The remaining 6 plans sacrifice universality for more choice. They're more opt-in than opt-out. They all preserve the employer-based insurance market and the individual market. They all charge premiums in some ways, and they all involve some form of cost sharing. But they still reshape the system in ways that involve expansions of government-sponsored health insurance. Some are through buy-ins. The idea here is that Americans, if they want to, can buy public insurance plans through Medicare. This mostly applies to people who are on the individual market, but there's variation. Let's dig in. Senators Merkley and Murphy have proposed the Choose Medicare Act. Their plan would allow anyone on the individual market to choose and purchase a Medicare Part E plan. That's what they're calling it. It would work like traditional Medicare. Like other Medicare for All plans, it would also improve Medicare by setting out-of-pocket maximums, which don't exist now. It would also increase tax credits to help people buy the plans and allow Medicare to negotiate drug prices. But it would lead to questions as to whether employers let employees go to Medicare up to employers. Companies want to stay on their own, they can. Premiums and cost sharing would continue. Representative Schakowsky and Senator Whitehouse have the Choice Act. It's not too dissimilar to the Choose Medicare Act, except it would only allow small employers to opt into Medicare with those in the individual market. Larger companies would not be allowed to participate. Representative Higgins and Senators Kane and Bennett have Medicare X, which is not an implementation of WebEx. It's similar to the Choice Act in that large companies are locked out and small employers can opt in. But there's one more exception. Medicare X would only be available to those in the individual market who only have one insurer in their area. This is meant to spur competition. It would also be available if costs were really high in one market. But if there are already options with an S in your area, no Medicare X. Medicare isn't the only program we could offer for sale, though. There's also Medicaid. Representative Lujan and Senator Schatz have offered the State Public Option Act. This plan would essentially let anyone who wanted to buy into their state's Medicaid program. Premiums would stay. Cost sharing potentially could, depending on how states design their plans. Being an opt-in plan, it also wouldn't call for an end of either the employer-based or individual markets. There are two other plans worth mentioning. They also attack the problem in different ways and also don't seek universality. The first, the Healthy America Plan, created by employees of the Urban Institute, creates a new plan for those currently covered by Medicaid, by CHIP, by individual plans, and the uninsured. It essentially just merges all of them together in one plan while not touching anything else, including the employer-based market or Medicare itself. The second is Senator Stabenow's Medicare at 50. It allows anyone between the ages of 50 and 64 to choose to buy Medicare plans if they want. If they'd otherwise get insurance through their job, their employer would pay their premiums on their behalf. This Medicare, though, would be Medicare as it exists now, with limits and cost sharing. So many who get their job-based covered would not find it as enticing as they might other proposals that improve Medicare before expanding. And those are the major plans at the moment. Some are really Medicare for all, ending private insurance and expanding the enhanced public program across the board. Some seem to expand enhanced Medicare to those already on public programs or those who are uninsured at this time. Others look to keep more of the current system intact and allow people the option to buy Medicare or Medicaid if they like. Others seek to try and reduce the number of uninsured with as little mucking with the current system as possible. These clearly have pros and cons. They will cost different amounts. They will require or not require new taxes, and they will disrupt the system we have now to varying degrees. But they constitute a range of options by which we can use the public insurance programs we have to further reform the insurance market. There's a breadth of ideas up for debate.
All right, so that obviously you don't have to know the details of all those plans that were put forward. I just wanted to highlight there's, all of those plans fall along a spectrum. And so some seek actual full comprehensive universal health care to barely changing the status quo. So that is kind of an overview. Obviously, some of these specific plans and bills have expired or are no longer being championed. But until we have Medicare for all, these half-measured plans will continue to be thrown out by people who want to muddy the waters on the healthcare debate. So that's kind of why I wanted to highlight those.
Now that we've set the ground rules.
And so SNaHP and PNHP both support the Bernie Sanders and Pramila Jayapal bills because they are the only plans that satisfy each of the following criteria. They expand Medicare to cover all medically necessary services, where other plans leave these essential services either be covered by private insurance or out-of-pocket expenses. They also eliminate all out-of-pocket expenses with an exception for potential some expenses on prescription drug prices that we'll get into, while other plans keep a lot more out-of-pocket expenses within Medicare, Medicaid, and private insurance. They are also truly universal, meaning that everyone is granted coverage under this plan, and no one has to navigate the fractured and hyperinflated private health insurance market. While Medicare for All is pretty well known at this point, and most people have a general sense of what it means, I did want to include this slide just to help define what we mean by single payer. Single payer just means that the government is the sole provider and singular payer of the health insurance in this country. So in these plans, Wall Street transaction tax, a payroll tax on businesses, and a progressively structured income tax, where the vast majority of Americans save thousands of dollars compared to their current health expenditures. They all go towards funding a private health, or go towards funding a public health insurance plan. And this public health insurance sends payments and reimbursements to privately owned doctors' offices and hospitals. So the claim that Medicare for All makes physicians and other healthcare providers government employees is inaccurate. And when we mention that Medicare for All covers all medically necessary services, this is what we're referring to. This is actually what's outlined in the bill. Just that. And there's also many economic upsides to single payer. First, it has a more progressively funding stream than our current system, since it's funded by progressive taxes based on the ability to pay and a modest tax on Wall Street. Next, the streamlined structure will provide immense administrative burden with which the private insurance industry imposes. Next, we will be able to also make healthcare more affordable and cost predictable for every patient by eliminating out-of-pocket costs. In addition, by having single payer, we'll be able to negotiate lower prices on drugs through increased bargaining power. Just some updates in the past year on these Medicare for All bills. A majority of House Democrats are now co-sponsors on Medicare for All, and we're getting increasingly more Democratic leadership support. More and more co-sponsors are signing on, and we are experiencing more public support and showcasing the benefits of single payer through congressional hearings. One actual cool thing to note about this is that PNHP members and leaders of the physician group for PNHP have actually been called upon several times to go to Congress and testify for the bill and promote its benefits. All right, so here we are. We're going to step away from the traditional talking points and do this the fun way by breaking down and summarizing each title in the recently introduced Standards Medicare for All bill. To prepare for this, I actually had to read the entire 134-page document, which is ironic because I never read for PI. We hope that by the end of this brief summary, you'll be well versed in the legislation. And more importantly, as we dive into tomorrow as well, you'll come to realize that a lot of the talking points or fear-mongering about Medicare for All are actually addressed or completely contradicted by the bill's language. And I've highlighted the titles above in red that answer or counter some of the common critiques of Medicare for All. In addition, we also hope that this reduces some of the fear of the unknown associated with the legislation. So Title I is pretty straightforward as it simply establishes Medicare for All when the bill gets passed, but it also highlights some important aspects of the scope of this plan and its rollout. Firstly, it sets a timeline for the rollout once the bill gets passed. In Section 106, as it specifies that if, for example, Medicare for All was passed today, it would take 4 January 1st dates for the full benefit to become active. And it allows this for a rollout period, which we'll get into later. As part of this rollout, all children and newborns will be automatically enrolled. When the full benefits take effect, every resident will be in the US will be in the program, and every healthcare service setting that will be considered in-network, which offers true freedom of choice for patients to choose their own preferred doctor. Resident also includes non-citizens like immigrant workers and people on their work or study visa. However, the Secretary of Health and Human Services reserves the right to make a ruling for travelers receiving non-cost sharing healthcare. This is meant to prevent people taking advantage of our new program. So people who are visiting here and have a healthcare emergency would basically be able to receive no cost sharing care, but people who will be held accountable for traveling here just to seek out our healthcare system. To be clear, Medicare for All does not eliminate private insurance, but it does prohibit insurance companies from trying to duplicate coverage that's already provided under Medicare for All. Title II outlines the comprehensive benefits that we already discussed in a previous slide. It also outlines the only out-of-pocket expenses that would exist under Medicare for All, as prescription drug fees would still exist. However, it sets a hard cap at $200 per year per person or per family, which, if anyone here is even aware, for diabetic patients, especially those who are on or underinsured, could pay over $400 per month on insulin alone. It also describes that most Medicaid services and billing will be replaced by Medicare for All. And lastly, this actually applies to the Secretary of Health and Human Services and the states, but neither can remove any services, standards, or eligibility from the outlined legislation in this bill. They can only add to it. In addition, neither the state nor the Secretary can revoke provider access to this program. This is really a protective measure for physicians and healthcare providers who are on both sides of political issues. A common fear of Medicare for All is that physicians would be expendable under the government and subject to losing their practice for taking a stand against their state legislature. This part of the bill removes any possibility of that happening. Speaking of provider access, Title III just outlines how physicians and hospitals can apply for participation in the Medicare for All program. This is basically the contract providers would sign for in-network status in a very similar way to how insurance works in the US right now. So Title IV just really outlines the administration hierarchy of the program. The Secretary for Health and Human Services will oversee its operations and collaborate with healthcare organizations, unions, and other organizations. The Secretary will also appoint regional directors, more on them later, and a beneficiary ombudsman who receives complaints, does quality improvement projects, and produces assessment materials for the public and for Congress. Title V just outlines how the Center for Medicare and Medicaid will evaluate the quality of the Medicare for All program and collaborate with other sectors on how to address additional health disparities after Medicare for All is established. While implementing universal health care is certainly the largest way we can address health disparities in the country, it isn't going to fix everything, so more work will need to be done. I actually need to take a drink of water here now. That's a halfway point, so you can look at some bags. All right, so now that we're nearly halfway through this bill, I just wanted to highlight what we've covered so far and what was still yet to come. Okay, so Title VI is pretty important and it's a pretty comprehensive section of the bill here because it mainly covers the entire budgeting for this program. So new to the 2022 bill, it actually sets aside part of the budget to cover temporary worker assistance program for health insurance workers who are most likely to lose their jobs after this bill gets passed. So it covers 5 years of full loss benefits as described here. To cover the payments and to the institutional and individual providers, I actually wanted to share a personal experience I had advocating to Washington on behalf of the AMA. As many of you are probably aware, the Medicare reimbursement rates for physicians is pretty low, and for Medicaid, it's even lower for physicians. So in the AMA informational meeting before we met with legislators, I got to see historical payment rates for Medicare to physicians, hospitals, and other provider clinics. And the data was interesting. In short, the payment rates to hospitals and every other healthcare setting has increased along with inflation for Medicare patients, except for physicians. The physician payments have basically stagnated over the past several years. So right now, Medicare payment rates for physicians are set by Congress, and the AMA has to constantly plead to the slow, dysfunctional legislative branch every 2 years or so, as the small increase in payment rates that we do receive have a very short lifespan. Under Medicare for All, the physician and hospital payment rates would actually be ran and set by regional directors who actually are instructed to work with a panel of physicians to set these payment rates in the first year of the rollout of the plan, and continually update them every year. So all of that data also has to be made to the public, and this gives overall physicians much more bargaining power as we are able to speak directly with an autonomous portion of the executive branch to set these payments to physicians. Also stay tuned tomorrow as we do talk about more how physician revenue can actually be increased under Medicare for All. So this title also crucially states, for the first time, the federal government can negotiate drug prices and the cost of medical devices while encouraging the use of as effective generics. This will save an enormous amount of money in our healthcare system. So Title VII is pretty straightforward. It just sets aside a section in the books of the Treasury for Universal Medicare Trust Fund. This is where all related taxes for Medicare for All will go. And then that fund actually pays out the reimbursements and costs to healthcare providers. Title VIII adds amendments to previous pieces of legislation to undo them or otherwise unify current healthcare benefits to just fall under Medicare for All. So, for example, here, like a lot of these previous pieces of legislation offered healthcare benefits to government workers, but now they're just going to be covered by Medicare for All, so they're no longer needed. Title IX is more or less the same as Title VIII. It also eliminates no longer needed programs. Again, this is where single payer overall just helps eliminate wasteful spending and complexity in our healthcare system. We won't need a separate Medicare, Medicaid, CHIP program, or ACA exchange markets anymore. Medicare for All does, however, leave TRICARE, the VA, and Indian Health Services unchanged as they serve a unique population that have developed a strong connection with those existing programs. All right, so going over the Title 10, transitioning to Medicare for All. Basically, there's 3 subtitles here. We have improvements to Medicare for during the transition period. So during that 4 years after it gets passed to when the full benefits become eligible, there is a section of this bill that eliminates deductibles and drastically reduces co-insurance threshold to $1,500. No person will have to pay any more than that in the system. It also forces generic drug use and lowers the prescription drug out-of-pocket threshold to $305, which again would become $200 per year after Medicare for All takes hold. It then also expands Medicare to cover dental and vision services and hearing aids and examinations. It also, I didn't know this was a thing, but people that have disabilities have to wait 2 whole years to apply for Medicare and actually get the services from that program because they want to make sure that you're, I guess, permanently disabled. But all of those people will immediately be put onto Medicare during this transition period. Also, this does prohibit any insurer of a Medicare supplemental policy from discriminating against pre-existing conditions, just as kind of like a normal tagline for this legislation. And then subtitle B describes the temporary Medicare buy-in option and temporary public option during this transition period. So the first January 1st date to follow the date of enactment allows Medicare buy-in for individuals 55 to 64. It lowers it by 10 years. And then each year after that, it just drops another 10 years for people to buy into that Medicare temporary option. And then section 1012 uses the ACA and Medicare Part A, B, and D billing rates to create a temporary public option for everyone younger than that age that wants to buy into a public option during this transition period. And then for subtitle C, talks about patient protections during Medicare for All transition period. Basically, the secretary should do everything they can to prevent disruptions to patient care, especially for patients with disabilities or complex medical needs. Title 11 just helps with some definition clarification. One piece of importance from the section is, if you were unaware, is that Medicare for All would apply to all US territories like Puerto Rico. And congrats, you actually just made it through the entire Medicare for All bill. So now you should be able to be pretty well versed on at least what's inside the bill and what's not inside of it. As a summary, Medicare for All implements a universal comprehensive healthcare plan with a 4-year rollout. In that 4-year rollout, it automatically enrolls children and newborns into the program. It creates a temporary Medicare buy-in and public option. It also improves Medicare during that 4-year transition by capping out-of-pocket expenses and improving access to additional services. It also provides 5 years of complete worker assistance to people in the health insurance industry. This also, when it's fully implemented, would drastically reduce out-of-pocket expenses for patients. It eliminates co-payments, co-insurance, premiums, and deductibles, and sets a $200 cap on out-of-pocket expenses for prescription drugs. Again, it covers all medically necessary procedures with an appeal process for experimental ones, and moves Medicare for All physician and institution payment rates out of Congress and into the executive branch, specifically those regional directors who work directly with physician panels. And then now that we're moving on from that, I just want to provide some quick highlights from updates on activism efforts. So on the state level, we're actually building momentum for state level single payer systems. So from 2010 to 2019, legislators in over 20 states have proposed 59 unique single payer bills. And some state bills like New York are increasingly close to passing. A few others are like Minnesota, and California has gotten close a few times. As of April this past year, we have been working with Public Citizen, and there are many opportunities to build momentum at the local level. So one example of this is actually through city level resolutions, which could be passed by city councils. This not only builds public support and positive media for single payer, it organizes the local community around single payer, which translates to increased state and national approval, as well as an important organizing for other local issues. So we actually are currently working with the Kent City government to pass our own Medicare for All resolution there. Max Brockwell, as a member of our leadership team, has been really leading that effort. In October, we are actually expecting to pass the Medicare for All resolution in Kent, because we actually have enough votes already for that bill to pass. So definitely stay tuned, because we'll actually be asking people to attend that city council meeting and show their support to get it passed. Okay, so thanks for coming again today. This is actually just a setup for tomorrow. There's a lot of talking points that get thrown around against Medicare for All, and some of them I'm sure are in good faith, but a lot of them aren't. So we'll kind of show you how to talk through those debate points. And yeah, definitely consider joining SNaHP. Thanks.